She serves on the Scientific Advisory Committee of the European and Developing Countries Clinical Trial Partnerships and was named one of the most influential figures in Danish health in 2022 and 2023. Without further ado, I'll give the screen to you, Dr. Benn, and we can get the webinar started.
Thank you, Ruby, and thank you for the kind introduction and the invitation to be present here today to share some of our work on vaccines in Africa and also to share some broader perspectives on global health and the EDTCP program that you mentioned. Let me start by sharing my slides here. And please let me know if you can now see my presentation in full screen.
Looks good.
Perfect. Yeah, so let me just jump directly to my disclaimer, which is a bit of an unusual disclaimer because talking about vaccines, I found it very important to mention up front that I'm not only a medical doctor, etc., professor of global health, but also the mother of 2 kids who received all the vaccines in the Danish vaccination program. I am going to say things about vaccines that would upset some people and easily could lead to attack of anti-vax. These are results that come from a scientific inquiry. I need to share this information with you, but I just also want to mention upfront, as I said, that I don't have anything against vaccines as such. I'm a believer, a big fan even of some very specific vaccines. So let's just clear that out right from the beginning. I also want to disclaim that I've spent part of the last 32 years in Africa studying the overall health effects of vaccines together with Peter Arby, whom I happen to see was also present for this webinar. And therefore, I'm with him a co-developer of this concept of non-specific effects of vaccines that I'll be talking about today. And that obviously makes me biased in that regard. I've seen a lot of study results that have convinced me that these effects are real. I hope to be able to share them with you and create some discussion and potentially also convince some of you that they are real. But one tends to get in love with one's hypothesis, and I have to declare I am in love with this hypothesis. But apart from that, I don't have other conflicts of interest, and my main funding bodies are mentioned here in this slide as well. So to set the scene, I just want to remind everybody what I think is obvious to anybody participating in this webinar, that a vaccine is usually considered a biological preparation that improves immunity to a particular disease. And this line of thinking guides how we evaluate and monitor vaccines, because that's usually done based on the effect of the vaccines on the vaccine disease, or even just on biomarkers for the vaccine disease. And then we know in the phase 3 trials and post-licensure, there's some assessment of potential plausible adverse events. But it has never been part of the assessment of vaccines to test the vaccines for their effect on the immune system's ability to handle other infections. And that is because it has seemed so obvious that the vaccine would only affect the immune system and the immunity towards the vaccine disease and nothing else, or in other words, the assumption is that the immune system would not learn anything from meeting one pathogen that could be used in the meeting with other unrelated pathogens. And this line of thinking really means that the current understanding is that one could sit behind a desk, and if one knows the burden of disease and the vaccine efficacy, then one can, and the adverse events, then one can calculate the effect of a given vaccine on overall health. So for instance, if measles vaccine is 95% efficacious, and measles, as it was when measles vaccine was introduced, constituted perhaps 10% of all death in childhood, then the introduction of measles vaccine would be assumed to be associated with more or less a 10% reduction in all-cause mortality. I want to remind you, this has never been assessed, this effect on overall health. This is simply extrapolation from knowing the burden of disease and the efficacy of the vaccine. And that has led to these estimates that you will see on a UNICEF brochure about how many lives you will save with a given vaccine. But again, this has never been attested. It's based on assumptions that the vaccines would not train the immune system and in a way modulate its ability to respond to other pathogens. But we've had reasons to question this assumption in Guinea-Bissau at our field station, which is in this small country with 1.8 million inhabitants situated at the west coast of Africa. In this country, together with the Ministry of Health of Guinea-Bissau, we have established a so-called health and demographic surveillance system. And that means in a country with no road names, no house numbers, that we have mapped all the areas where we worked with each house literally painting its number on the house. We've done censuses, we've registered all inhabitants in the areas, and then we follow a population corresponding to around 200,000 individuals, with which all have a personal identifier. And at the home visits, we register all the vaccines they have received, all other interventions, and their infections and their hospitalizations, which are also captured at the nearby main hospital, which has the country's only pediatric ward. So that means that we have been able to do these studies that nobody actually ever did, to study what is the effect of vaccines on overall mortality and morbidity, not just the vaccine-specific mortality and morbidity. And that inquiry led to contradictions of the current paradigm for vaccines, because it very clearly and early on became evident that the effects of a vaccine observed in real life, the effects on overall health, could not be explained based on the protective effect against the vaccine disease and the few known adverse events. For instance, with measles vaccine, which was only assumed to reduce all-cause mortality by perhaps 10%, when it was rolled out in Guinea-Bissau, and this was subsequently confirmed in 4 other countries, in a naive population, measles vaccine in all the 5 studies reduced all-cause mortality by more than 50%. So much more than could be explained by the prevention of measles infection. And in contrast, there were other vaccines that should have reduced all-cause mortality because they prevented very dangerous and deadly diseases like diphtheria, tetanus, and pertussis, where the anticipated effect on overall mortality was not evident. Even in some situations, these vaccines were associated with increases in overall mortality. And since mortality in Guinea-Bissau at that time, and still child mortality, was mainly caused by infectious diseases, this led to this hypothesis that the vaccines, in addition to their well-known protective effects against the vaccine disease, also have what we coined non-specific effects on other diseases, on other infections, which in some situations for some vaccines were extremely beneficial, protecting against a broad range of deaths from a broad range of other infections, but in other situations looked as if they could be harmful. The most well-known example, and I also think the only one that really led to a major change in policy, was the example of the high-titer measles vaccine. This was a new measles vaccine and not the one I talked about so far in the presentation. This was a vaccine that had a very high titer of measles virus, and it was very filled with, there were a lot of expectations for this vaccine because it was so potent that it could immunize in the presence of maternal antibody. So it was introduced by WHO in low-income settings in 1989. And as mentioned, it could be given as early as 4 to 6 months of age, in contrast to the standard measles vaccine, which only is given from 9 months of age. And it was still fully protective against measles infection. That was established at the time it was rolled out. But it had only been studied for its effect on antibody and on clinical measles, according to, as I mentioned in the beginning, this current paradigm for vaccines. But independent researchers did randomized trials, and among them Peter, who is here, looking at the effect of high-titer measles vaccine around 4 to 6 months versus the standard titer measles vaccine at 9 months. And what came out was this very surprising observation where you have in blue the males, in red the females. You have on the left-hand side Bissau, on the right-hand side Senegal, where the study was repeated. And you can see that the control group that received the standard titer measles vaccine, there's really no difference in mortality for boys, in boys, there's no difference between those in the control group that received standard titer and those in the intervention group that received the EZ high titer measles vaccine. But for girls, it made a profound difference in both studies in the range of a 2-fold higher mortality. We have the survival probability on the y-axis, and you can see the curve that really stands out is the girls who received the new high-titer measles vaccine. They had around 2-fold higher mortality than the control girls who received the standard titer measles vaccine. So this was the first and perhaps most well-known and well-accepted example that a fully protective vaccine could have these non-specific and also, in this case, sex differential effects. And this had nothing to do with the ability of both vaccines to control measles infection. They were both good at that. But somehow the EZ measles vaccine hampered the girls' ability to combat other infections, which meant they succumbed more to other infections and died more from other infections. So the immune system was impacted in a negative direction. This was not a trivial observation. It was later repeated in Sudan and Haiti, and WHO withdrew the high-titer measles vaccine in 1992. And yeah, not trivial observations in the sense that if the vaccine had been continued on the scale of Africa alone, this would have caused around 500,000 additional deaths every year, which would probably not have been noticed because these are settings and these were times, especially where no children were registered, whether they were born or died. So this is just to say that these are effects that have an enormous impact on population level in areas with high mortality. Unfortunately, at that time, there was really nothing done to look more into how a vaccine that was fully protective against the vaccine disease could impact the immune system so negatively that it led to, in spite of protection against the vaccine disease, it led to increased overall mortality. But that was, among other observations, the positive effect of the standard measles vaccine and other observations, the start shoot for Peter and later me to start looking into in a very systematic way the overall health effects of all the routine vaccines used in our setting. I want to dwell on a few of these vaccines. I don't have time to go through all the investigations we made, but I'll start with the Bacille Calmette-Guerin vaccine against tuberculosis, the BCG vaccine, probably well known to most of you, or all of you. When we started studying this vaccine, we could see in observational studies comparing those who got the vaccine versus those who didn't get it, that they had much lower all-cause mortality and much more than seemed explainable from the prevention of tuberculosis, which isn't a big killer in the early infancy and childhood. So these observations led us to do a randomized trial, and it should be appreciated that it's super difficult to do randomized trials with vaccines that are already part of a vaccination program, because it's often very ethically problematic to either not vaccinate or delay vaccination with already approved and scheduled vaccines. But in the case of BCG vaccine, we had a fantastic opportunity because when we started our trials, low-weight neonates in Guinea-Bissau and many other African countries didn't receive BCG at birth. They were considered too immunologically immature. So therefore, they got a delayed BCG around 6 weeks of age, together with the first diphtheria tetanus pertussis vaccine, marked DTP vaccine here on this slide. So you can see that created a possibility for doing randomized trials where low-weight neonates were randomized to receive the usual oral polio vaccine at birth and then BCG and DTP at 6 weeks, versus the intervention group that received BCG already at birth together with OPV and then just DTP around 6 weeks of age. And to cut a long story short, we have the results here of 3 such trials that we did in 3 different underlying mortality settings. So you can see the light gray bars show the mortality in the control group that followed the usual program, and mortality was quite different between the 3 different trials. But you can also see consistently reductions in all-cause neonatal mortality. This is among those who received BCG in the trial. And in a combined analysis of these 3 trials, receiving BCG at birth was associated with more than a third reduction in all-cause neonatal mortality. And based on verbal autopsies and hospital records, this was mainly due to non-specific protection against septicemia and respiratory infections, nothing to do with tuberculosis, which doesn't kill children in the neonatal period, or only very rarely so. So this really points towards a very beneficial non-specific effect of the BCG vaccine, protecting neonates not only against tuberculosis in the long run, but also in the short term against a broad range of other infections which would otherwise or could otherwise have led to their death. WHO reviewed the evidence for non-specific effects of vaccines, and more specifically of BCG, DTP, and measles-containing vaccines in 2014, and the review was published in BMJ in 2016. And a meta-analysis of the, at that time, 5 randomized trials and 9 observational studies that were included in the review pointed towards that receipt of BCG may reduce overall mortality by more than expected through the effect on tuberculosis. Since the WHO, several other studies have been published. There was an Indian trial that didn't find an effect. We have several potential explanations for that, among others, the strain of BCG that was used, which is a weaker strain of BCG, and also that the children were quite ill, and many of them, or few of them, died from infections, but many of them died from congenital malformations, birth trauma, etc., things that we don't really think that BCG would work against. But here we have a study from Uganda, which was published in 2021 by an independent group, randomizing both low weight and normal weight children to receive BCG at birth or at 6 weeks, and up to 6 weeks when the control group received BCG, there was a 29% significant reduction in non-TB infectious diseases among those who got the BCG vaccine at birth versus delayed. So confirming the findings from Guinea-Bissau. So this has taken a long time to get accepted, and I think the most important factor in getting more acceptance of these findings was that we were able to identify, or not we, but an immunological mechanisms was identified. Because you can see here, sorry, this is after the publication of our second trial of BCG. We have a letter to the editor from professors at London School of Hygiene and Tropical Medicine, noting that they find it unlikely that an immunological mechanism could explain a rapid effect of BCG on neonatal mortality. Note the date here, February 2012. Here in October 2012, comes a paper from Meagher group in Nijmegen. They have been instrumental in showing that the immune system not only, well, it has the adaptive and the innate immune system, but showing that the innate immune system actually has a memory, it can be trained. And the way they found out was by looking at BCG vaccine and noticing that, and showing very neatly that it induces epigenetic modifications in the monocytes that lead to a more vigilant phenotype of monocytes, which could explain why BCG could induce even very rapid effects on neonatal mortality by strengthening the innate immune response. So I usually teach my students that this is a very good example that one shouldn't only look at biological plausibility when deeming an epidemiological finding relevant or not, because it might very well that we have might very well be that we just haven't identified the mechanism yet. So with Asimov's word here, today's science fiction is tomorrow's science fact. These immunological mechanisms have been confirmed in a number of studies as epigenetic modification by BCG. And here I think is a very important piece of evidence also showing that this actually matters for the in vivo response to other pathogens. Because here in a very neat study done by Meagher group, which we were fortunate to participate in this particular trial, Dutch volunteers were randomized to BCG or to placebo. And then 4 weeks later, they got a yellow fever vaccine, and that induces viremia on day 5. But by taking blood samples before and after, it was shown that viremia was reduced significantly in those who had received BCG 4 weeks prior to the yellow fever vaccine. And this was linked to epigenetic modifications of the monocytes, leading to not least more IL-1 beta production, which then correlated negatively with the viral titer. So I think this is a fantastic study because it really shows in a very nice manner how meeting a bacterial vaccine can profoundly modify the way that you respond to a viral challenge down the road 4 weeks later here. BCG is actually pretty marvelous because at the same time as it induces more aggressive innate immune cells, it also dampens systemic inflammation in the steady state. So this is just systemic plasma inflammation, which is higher in males compared with females in normal adults. But after BCG, BCG reduced not least the level in males down to the level of that seen in females. We actually see the opposite that's unpublished so far, but in babies, it's the females who have the highest level of systemic inflammation, and BCG dampens their inflammation. So somehow BCG, at the same time of strengthening the innate immune system, also dampens inflammation, and mostly so in those who have the highest level of inflammation. And that has led to a number of speculations and groups now having very promising results showing that BCG might not only strengthen African babies' immune response towards infections, but actually also influence conditions as different as diabetes, as lung cancer, and Alzheimer's disease. So I won't dwell on that, but just tell you that there is a promising line of research and inquiry into BCG vaccine. I'll jump to another live attenuated vaccine, the oral polio vaccine. Actually, studies back in the 60s and 70s in Russia showed that oral polio vaccine was effective against influenza, reducing morbidity by up to 60 to 80%, which is quite a lot more than we usually see with the normal influenza vaccines. This was beautiful work, but mostly done in Russian or published in Russian, so not a lot of it is accessible for us, but there is this paper that I'll recommend, and really the studies were fantastic, including hundreds of thousands of people and worth looking into. On our inquiry in Guinea-Bissau into the effect of vaccines, we had a small observational study that suggested that actually oral polio vaccine at birth could be harmful for males. It was a puzzling observation, but we found it strong enough to justify a randomized trial of oral polio vaccine at birth, and that we did from 2012 to 15. And here you can see the cumulative mortality for children who were randomized to BCG plus OPV or just BCG. And if we looked at the children up to the time point, at that time there were many oral polio vaccine campaigns. When we looked up to the time point when children received oral polio vaccine in a campaign, there was a 32% reduction in all-cause mortality in babies who had been randomized to OPV with their BCG versus those who didn't receive OPV. And this was a sex differential effect, so the effect was clearly strongest and significant in its own right in males, and this is a finding that we have reproduced again and again, that males seem to benefit more from oral polio vaccine. This trial was done in a context with no circulating polio virus, so this is clearly a purely non-specific effect of the oral polio vaccine, which seems to indicate that in line with what we saw for the BCG vaccine, OPV can strengthen the baby's immune response against other infections. So with the OPV, you don't only get protection against polio, but also against other infections that could kill otherwise. Yes. We have a number of studies ongoing. It's spearheaded by Sebastian Nielsen from our group. He has initiated collaboration with a number of African and Asian countries to look into the effect of all polio vaccination campaigns on all-cause mortality, because these campaigns, as mentioned, they have been very frequent in the last 20 years, and nobody has ever looked into whether they could impact overall mortality. They were just given to prevent polio, and nobody anticipated any effect on mortality. First of all, there was little polio. Secondly, polio rarely kills children. Nonetheless, when we started looking into polio campaigns, comparing children as their own controls, their follow-up time before and after a polio vaccine campaign, we find consistently strong effects of oral polio vaccine against all-cause mortality. So we have had a period with all these polio campaigns here. As I mentioned here on the upper graph, you can see the frequency of oral polio vaccine campaigns. And in the lower graph, you can see that obviously this also corresponded with a decrease in the reported cases of paralytic polio. But the really intriguing thing is that in our calculation, these OPV campaigns may actually explain a considerable part of that decline in child mortality that has been in Guinea-Bissau and low-income countries and in the world as such during the very same period that the oral polio vaccine campaigns have been rolled out. So the findings on BCG and oral polio vaccine, these live attenuated vaccines strengthening the immune system, apparently reducing all-cause mortality, led us, together with Konstantin Chumakov, who was actually the son of Marina Voroshilova, who did the old oral polio vaccine trials in Russia, And Robert Gallo, that you all know, of course, whom you all know, led us to propose in the beginning of the COVID-19 pandemic that the live vaccines could be used to protect partly against COVID-19 incidence and severity until specific vaccines became available. And I'll just briefly run you through the results of the randomized trials that were done with these vaccines during the pandemic. We did a study in Guinea-Bissau, a cluster randomized trial, and you can see here from the curves that we had a very profound effect on males who received oral polio vaccine versus no oral polio vaccine. So they had an almost 30% reduction in the risk of the composite outcome of being admitted or dying or being admitted or consulting from infections, whereas we really didn't see any effect in females. So this is in line with what I showed you for the neonates, and what I told you is actually a consistent feature. We see stronger effects of oral polio vaccine for males than we do for females. In Russia, a similar study was done, and that also reported significant effects of oral polio vaccine against, in this case, they had lab-confirmed COVID-19 as their outcome. Unfortunately, the data wasn't reported by sex, so we're not able to tell you whether this effect might also have been stronger among Russian males than Russian females. But I think taken together, promising suggestions that oral polio vaccine could in fact be a stopgap vaccine against new pandemic threats. And here I think the most intriguing piece of evidence, something that we are just now submitting, we have collected all the deaths that were reported in all the trials studying BCG against placebo during the pandemic. 11 trials reported death in their trial and by intervention group. And you have them, I don't know if you can see my arrow here, but you have them here in this column, all the death in the BCG and the control group. And when we combine it all in a meta-analysis, well, then during this short follow-up in these trials, between 6 to 12 months, BCG was associated with 45% highly significant reduction in all-cause mortality. So the effect of COVID-19, I forgot to say, it was actually quite variable. It was apparently there for the weakest study participants, but not in healthy healthcare workers, for instance. But the effect on mortality was consistent both in high-income settings and low-income settings, in the elderly and the healthcare workers, and suggests that BCG may be another tool in the toolbox should a new pandemic arrive. This slide, just a short mentioning that we just published a trial here in 2024, a cluster randomized trial where we randomized children to a home visit recommended by WHO, not implemented in Guinea-Bissau. And half of the clusters received BCG and oral polio vaccine at these home visits. That's also not recommended by WHO, and half just received the home visit. And what we showed was an almost 60% reduction in the risk of non-accident mortality up to 6 weeks of age in the clusters that received the vaccine. So that points towards a very simple intervention. The addition of vaccines to the home visit recommended by WHO could have a profound impact and potentially also point toward some kind of synergy between the two vaccines. So the studies I've shown you up to now were only studying one or the other vaccine. In this trial, we are studying both versus none and seeing this additionally strong, what appears to, in early days still, we need to confirm it, appears to be a synergy between the two live vaccines. So what we have learned from BCG and oral polio vaccine is that they and other live vaccines, live attenuated vaccines like measles vaccine and smallpox vaccine have effects that cannot be explained by the prevention of the target disease. And we also have some potential immunological mechanisms to explain it. These findings are getting increasingly recognized, and in 2020, Nature made the discovery by Peter and our group a milestone in vaccines, the discovery of the positive beneficial non-specific effects of vaccines. And in the latest edition of Plotkin's vaccines, there's a whole chapter on non-specific effects. The findings have implications for have many implications, and one of them I just want to briefly mention is that maybe it would be good, since these effects are seen as long as a vaccine is the most recently received vaccine, to make sure that children have live vaccine as their most recent vaccine throughout infancy. And here I show you the Danish and the US vaccination program. And the Danish program is actually quite good in having live vaccines from 18 months to up to 5 years of age. So the major part of childhood is actually dominated by a live vaccine, the MMR vaccine. But you can also see, for a comparison, the US schedule, where children rarely receive a live vaccine alone. And that might actually matter, as indicated in this study from CDC, where you can see that among more than 300,000 children, those who had a live vaccine as the most recent vaccine had a 50% reduction in the risk of hospitalizations for non-targeted infections. And the risk for those who received concurrent live and non-live vaccines was in between, so to speak. But it suggests that these beneficial effects of the live vaccines may also have implications for children in high-income settings, fortunately not dying from infectious diseases, but getting hospitalized for infectious diseases, and maybe their immune system could be strengthened as well with live vaccines to provide a healthier childhood. The findings also have implications for the testing, approving, and regulating vaccines. I'm running short of time, so I'll just briefly say that we published recently that we think that we need, in light of this new evidence, to revise how we do phase 3 and phase 4 trials, because we simply need to capture all-cause infections, all-cause morbidity and mortality, both in the phase 3 trials, but we also need more systematic evaluations once the vaccines are being rolled out, not just observational data, but maybe randomized trials, or at least some kind of step-wedge rollout of vaccines that allow for an assessment of their overall health effect, not just their effect against the vaccine disease. And this, for instance, I think is illustrated in the case of COVID-19 vaccines. They were not tested for their non-specific effects, but we went back to the phase 3 trials and captured all the deaths that we reported in these trials, did a meta-analysis the same way as I presented it for BCG vaccine, and we looked separately at the mRNA vaccines versus placebo and the adenovirus vaccines versus placebo. And what pans out here is that the adenovirus vaccines actually reduced all-cause mortality. They did it by reducing COVID-19 death, but they also reduced the risk of cardiovascular death and of non-accident, non-COVID death, that group where we would anticipate some non-specific effect if present. So it seems to us that adenovirus vector vaccines behave like live vaccines, and they are built also on a non-replicating, if non-replicating, still live adenovirus. So really, this does hint that it might have had beneficial non-specific effects and potentially was stopped for the wrong reasons. So if one had a focus on overall mortality, it might actually have been better to continue with adenovirus vector vaccines and mRNA vaccines. I definitely would prefer one based on these numbers. Yes, I'll just briefly, because I was asked and invited to talk about the global health perspective, talk about the pandemic in Africa, and there I want to mention the fact that it was very early on spotted that there might be some less impact of COVID-19 in Africa. And here you have the maps of the cases, the death, the test, and the vaccinated, and obviously the lack of tests could have impacted the low number of cases and deaths reported in kind of in between Africa, in between North and South Africa. But you'll see also that there were also very few vaccines there. So there's something puzzling. There seemed to be something puzzling going on with a greater impact of the pandemic in the northern and southern parts of Africa, but not in between, as mentioned. In Guinea-Bissau, due to our health and demographic surveillance system, we did a number of studies that allowed us to assess all-cause mortality. And I'll not mention all these numbers, but just tell you that the overall message from the different studies we did, where we captured mortality during a certain period of the pandemic, was that if anything, we saw lower all-cause mortality than in the previous years or in comparison, other relevant comparison groups, national statistics, etc. So while we were sure, we very early on in November 2020 did a sero survey just of our studies, our health field station staff, and saw that already at that time 18% were IgG positive. Few of them had really noted that they had been ill, and by the end of 2023, 99% had anti-N antibodies. So we know that the pandemic was there. We know it impacted very early on a lot of individuals, but it didn't seem to have a strong impact on mortality. And of course, we all ask ourselves, what are the reasons? I think, to me, one of the most interesting hypotheses is the one shown in the bottom here, that there is some intriguing evidence that having intestinal parasites could modulate COVID-19 severity. The data, the genomic surveillance data reveals that actually the epidemic in most African countries came from Europe, but it also showed that there was an ongoing transmission and that there was also new variants of concern. And I think it's worth mentioning, I don't think I speak with anybody here in this audience who disagree, but it was a big problem that vaccines weren't rolled out faster in Africa on the continent and targeting those most vulnerable individuals who also probably were some of the sources of the new variants of concern. But on the other hand, I think there is a controversial issue that I'd like to take up here, because there has been this kind of rebounds wish for more COVID-19 vaccines in Africa. And actually, I think I agree with the authors of the last paper shown on this slide here, that there is reason to reconsider whether COVID-19 should be used in Africa, because there is a cost of using COVID-19 vaccines. And if we look at the demographic and epidemiological specificities of the population, then the low risk of COVID-19 and COVID-19 death in Africa, at the same time as the priorities, other more urgent priorities, makes it worthwhile to discuss whether it's actually should be the priority to use COVID-19 vaccines in Africa. So what we have learned was that Africa, apart from North and South, actually did pretty well. We still need to understand better why. The vaccination started too late, at a risk of both vulnerable groups and new variants. I've shown you that I think the existing vaccines, BCG and all polio vaccines, could have provided partial protection against all-cause mortality during the pandemic and might be worthwhile considering for future pandemics. I have shown you how COVID-19 vaccines have not been investigated for their overall effects on overall mortality. And I don't think there is a clear need to allocate resources to COVID-19 vaccines. And then I think there's also, fortunately, a great chance that Africa will do better in future pandemics. So maybe they don't need to follow the same restrictions as other parts of the world, because in fact, the restrictions might have been the worst part of the pandemic for African countries like Guinea-Bissau. My very last slide here is a little bit of an advertisement. Ruby told me that you might be interested in hearing more about EDTCP, where, as mentioned, I've been on the Scientific Advisory Committee since 2017 and followed the transition from EDTCP2 to Global Health EDTCP3 under EU. It is a fantastic partnership funded by EU and funding research done in collaborations between European and African researchers. And it is a program that has contributed so much to doing many of the key randomized trials that have been done on the development of new vaccines against TB, HIV, and malaria. It is funding, still has a lot of money to fund randomized trials, but also implementation research, basic research in Africa in collaboration between European and African researchers, but not excluding researchers from elsewhere. And they have just closed a call for proposals, but they are coming all the time. So keep a lookout for those if you're interested. And also note that the 12th EDTCP Forum, a wonderful conference, is taking place in Rwanda in June, and registrations are still possible. So with that, I just want to thank all the people involved in our studies, thank not least here are some of the main collaborators, and also the women and children of Guinea-Bissau who come to get vaccinated every day, trusting that they get the best of vaccines that are meant for their children to grow up and become healthy toddlers like those here on the right-hand side. And we need to continue to work deliberately to maintain and be worthy of their trust. And with that, I also want to thank the audience for your attention and happy to take any questions.
Thank you, Christine. That was absolutely extraordinary. This is Stan Vademund. I'm here from my technological difficulties getting on early on, but Ruby helped me solve them, and I heard your entire talk. I just missed the pleasure of introducing you. So we have Stuart Isaacs is asking, did BCG vaccination prior to yellow fever vaccine decrease the effectiveness of the yellow fever vaccine due to decreased viremia?
That's such a good question. Unfortunately, no. So we measured antibody titers subsequently, and they weren't diminished in the group that had received BCG.
There you go. And Joseph Anejo Okopi asks, hello, Christine. Does this mean that some children were not vaccinated with BCG and OPV? What is your take on the ethical and social implications of not vaccinating those children?
I assume that you refer to our cluster randomized trial where I showed that we compared those who received BCG and all polio vaccine versus no vaccines. And I clearly understand and appreciate the question, but it should be noted that these were children born at home, and they didn't, the health system in Guinea-Bissau doesn't offer home visits, and it doesn't offer vaccinations unless you bring the children to the health center. So what we were doing was randomizing children to, all children in our study received a home visit that they wouldn't otherwise have received. And half of them, in addition, received BCG and all polio vaccine. We told everybody to go to the health center and get vaccinated. So we didn't, there was not one child in the trial that got less vaccines than it would otherwise have gotten, but there were many children who got more vaccines and earlier vaccines than they would otherwise have gotten. So the setting there allowed us to do this study in an ethically justified manner because no child was deprived or delayed in vaccinations. In contrast, some children got offers that they wouldn't otherwise have gotten. But in a setting where these vaccines were part of the routine, of course, this trial would have been deeply unethical.
Crystal clear answers. Thank you. Stuart Isaacs had a second question. He mentioned how much he enjoyed the presentation, how fascinating it was, but he was concerned he may have misunderstood. Does childhood BCG vaccination provide lifelong protection from other diseases?
Also a super good question. Most of the vaccines and their non-specific effects, maybe because they are due to epigenetic modifications of the innate immune system, can be changed when new vaccines and probably also new infections occur. So we see the non-specific effects most pronouncedly in the period where a given vaccine is the most recent vaccine. But specifically for BCG and smallpox vaccine, which happens to be, and we're speculating it might be related, they are the vaccines that are given intradermally, which actually establish an infection in the skin, which leave a scar, that these vaccines are associated with long-term impacts that for these vaccines last, we have shown in Danish data, up to 45 years of age. So kind of overriding with whatever comes afterwards. For BCG, we also know something about the potential mechanism because with Mihai Netea's group, we have shown that BCG enters the bone marrow and it trains the progenitor cells of the innate immune cells. So in that way, we think we can explain why these effects may be long-lasting because they actually profoundly change the phenotype of the progenitor cells. I would say for all vaccines, but for BCG and for smallpox vaccine, the vaccines, the non-specific effects seems to be very long-lasting.
And of course, we use BCG to treat cancer.
Yes.
Bert Jacobs has a question. Do you have any idea why the high titer measles vaccine was counterproductive?
Yes, that was something that was puzzling to Peter for at least 10 years because it was a live attenuated vaccine and there was really no reason why it should not follow the pattern that we saw for other live attenuated vaccines. But it turned out when we started looking at DTP vaccine, we saw that it didn't have the same beneficial effects. And as I mentioned, it's the last vaccine that dominates. High titer measles vaccine was given so early, so many children got DTP vaccine afterwards. So by 9 months of age, those in the high titer group would have a DTP vaccine as their most recent vaccine, but those in the standard titer measles vaccine would get the standard titer measles vaccine. So from 9 months and onwards, you would, and actually earlier, the children got in the high titer measles vaccine got DTP earlier. So during the follow-up period, the high titer group was dominated by a non-live vaccine, but the standard titer measles vaccine was just the live vaccine. And that turned out to really explain the data, because when Peter stratified the high titer group by whether they received or didn't receive DTP vaccine afterwards, the whole of the increased mortality compared with standard titer measles vaccine was in the group that received DTP afterwards. So the real culprit might actually not have been high titer measles vaccine, but the fact that it was given so early that children got a non-live vaccine afterwards, and that abrogated that benefit from high titer measles vaccine. I hope it made sense. It's a little technical.
Made sense. Boy, this one's a good one from Frank Pullman. He's recalling a study where the type of vaccines and the order in which they're given might increase or decrease all-cause mortality. So he wants you to comment. Maybe you can recall the study he's trying to think of.
I think it might have been this high titer trial, actually.
Yeah, maybe
it
the same one.
That the high titer changed, given so early at 4 to 6 months of age, changed the sequence of vaccination from, it was then live, non-live, versus the standard titer group that received non-live, then live. So, and we have repeated that observation a number of times, that that we can see that it's really in contrast to what we know about the specific effects of vaccines, where it rarely matters in which sequence and combination you give vaccines, you'll get your antibodies no matter what. Then for the non-specific effects, sequence and combination is extremely important.
So interesting. I think there's a lot more work to be done on that question. Because there are so many different combinations and strategies one could use. It'll be a very carefully thought through study that tackles that. Now, Natalie Meisinger asks, would you recommend giving a TB vaccine post non-attenuated vaccines in an effort to reverse the negative non-specific effects?
Yes. So we are actually currently starting up a trial in Guinea-Bissau, where we have just gotten ethics permission to do randomization by the time of the third DTP vaccine to a second BCG vaccine or no such second BCG vaccine. Because the data from the WHO review I showed you, they looked not only at BCG, DTP, and measles-containing vaccine, but they also looked at the sequence and combination. And it came out very clearly from that meta-analysis that receiving BCG and DTP at the same time was much better than receiving DTP alone. So this is the observation that we will now pursue in a randomized trial to see if with this second BCG vaccine, we might alter the course for the children up to 9 months of age.
Wonderful. And she also wanted to know if there was a cutoff age. For example, would a 5-year-old with their last vaccine being a DTaP benefit from TB as their subsequent vaccine?
Yes, so one trial I would be eager to do, and I'm currently actually writing a paper together with an American professor proposing 8 randomized trials that we would love to see done in relation to the current US schedule. And I think there you can kind of mix and switch between having the Tdap or MMR vaccine at 4 and 5 years of age. And it would be obvious for me to look into whether there are actually benefits of either or. And my prediction would be it would be better to take them in the order of first Tdap, then MMR versus the other way around. So right now, I think it's more or less up to chance, but by randomizing, we could actually investigate this in a systematic manner, and data suggests that there might be health benefits from using one schedule over the other.
Can I also ask you about the male-female difference? We usually think of the male disadvantage when we think of biology. And here you've repetitively found in your own work and that of others a male advantage in terms of the immunologic booster effect. And these are children, they're pre-pubertal. So I have a hard time getting my arms around this difference. I'm sure everybody does. But what are your speculations?
Yeah, they are still speculations. We have published several reviews with people who are wiser than us at studying sex differences. For instance, with Sabra Klein from Johns Hopkins, who is an expert on sex differences and the response to vaccines. And it's well known that females respond more with more antibody to specific vaccines, more specific antibody to vaccines than males do. And Sabra's work, among others, suggests that you could just fractionate influenza vaccine basically, and you would have the same antibody response in females if they got half or even a third, I think, of the dose of males. So there are differences also in childhood. And what we speculate in these reviews is that, I mean, there might be genetic differences. We know many of the immune system chromosomes, immune system genes are placed on the X chromosome. It might be related to hormonal differences, because even though they are subtle, there are differences in hormone levels already in pre-puberty. So these are some of the speculations, but we haven't nailed it yet, to cut short.
The other thing that comes to mind, that was very helpful. The other thing that comes to mind is the fact that you've occasionally found a negative effect from selected vaccines on all-cause mortality. And would you speculate a little bit further on that beyond what you've mentioned in your talk?
Yeah, so this is a very controversial and problematic observation, but unfortunately also very consistent, that we have seen for 6 non-live vaccines now, that they are receiving them for females is associated with higher all-cause mortality than not receiving them. Many of them were done in situations where there were herd immunity to the vaccine diseases, but some of them weren't, and they still suggest that they're, I mean, in both contexts, it suggests that these vaccines, for a period, they come with a price that they hamper girls' ability to fight off other infections. And we can see that for the most clearly for the DTP whole cell pertussis vaccine that is used in Africa, that there we have more than a dozen studies pointing in the same direction, that girls who receive this vaccine have higher mortality than those who haven't received it. They have higher mortality than boys during the period where they have DTP as their most DT whole cell P as their most recent vaccine. And that switches again when they receive measles vaccine. So I mean, the hopeful message here is actually you can give a live vaccine and abrogate it, but of course it's problematic with this signal of safety signal in children and in a dose-dependent manner. So we can see how the female-male mortality ratio among vaccinated children increases with each dose of DTP vaccine until they receive measles vaccine, and then it switches around with girls having lower mortality than males after measles vaccine. Yeah, so that is a headache, and it's something we hope will be investigated, because the current strategy from WHO, I'm sorry to say, has been to review it. I don't know if you noticed on my slide, but actually the review indicated a 38% increased mortality after DTP. I didn't show you the slide, but we have updated that meta-analysis with 2 additional studies done after the WHO review. And now it's a clearly significant, they point in the same direction, it's a clearly significant increased mortality, which shouldn't be there in these observational studies, because we know that those who get vaccinated tend to be healthier from the beginning than those who don't get vaccinated. So any indication that vaccinated children have higher mortality is really problematic. But that was seen and noted by WHO in 2014. As mentioned, the signal has only gone stronger, but there's been no real attempt to look into this. And that is frustrating because I just want to mention, I didn't say that, but there was an Australian researcher who used a professor of pediatrics who used the estimates from the WHO review to calculate the mortality benefits associated with just changing the schedule of using the existing vaccines in a different manner, making sure that children got a live vaccine with or shortly after their non-live vaccine, had the potential to reduce global child mortality by 1 million deaths per year. So again, it's not trivial numbers, and therefore, if we have the faintest indication that this is actually a potential benefit from using the same vaccines in a more clever way, optimizing specific and non-specific effects, I can't come to understand why there's not much more done to pursue this.
Wonderful. This has been an extraordinary hour, and I want to acknowledge your colleague, Peter Orby, who's also on the phone. And I know that you're a strong team in Denmark and in West Africa, but we really appreciate here at the Global Virus Network the opportunity to disseminate your work, and we welcome you to engage us further as we go forward. I just might mention that although we are seeing vaccine hesitancy research canceled by the NIH, we're seeing work in LGBT health canceled by the NIH. Given the interests of RFK Jr. and some of his biases, studying optimized approaches to vaccination may actually be of special interest at the NIH at the present time. Maybe not for the right reasons, but it doesn't matter if they would support work like this. So keep that in mind as we go forward. And if any of us in GVN can be of use to you, let us know.
Thank you very much. And just also a warm invitation to anybody in the audience who might be interested in collaborating. We're always looking for new collaborations, and we have a fantastic field station in Africa. We also have nice Danish registers to explore all kind of things around vaccines and viruses. So reach out if any of this has caught your interest and you're interested in collaborating.
1,000 thanks. Tusind tak.
Wow, that was Danish. Tusind tak from me as well.
Jeg er norsk, vet du. Adjø.
Adieu.